Ladies and gentlemen, thank you so much for joining us for today's webinar, the third in a series that is geared primarily for those of us who work in the health sector or who have interests or are stakeholders in the health sector and who want to have a much better understanding or a much more robust debate around what we are doing and what we could be able to do better. As the third in the series, maybe it might help for me to put a little bit of a context. We started off this series of conversations by looking at the aspect of communication and behavior change communication after having an overview of what this pandemic was all about, what coronavirus was all about, and COVID-19. And so we looked at the element of behavior change communication, considering the fact that this was the big issue around then, whether the communication that was getting out there was getting us to the desired results. We did unpack that, and we understood, or we came out with 2 or 3 critical things. That an understanding that there's quite a lot of wrong information and misinformation that is tending to bury the right information for a number of reasons. And so in order for us to be able to crack that so that we can get individuals, families and communities to be taking up the right health promotive or preventive behaviors, it is important for those who are designing these communications to really find a way of packaging this information, making use of the right channels so that they can be able to reach the right audience. Audiences differ, and the package so far and the way the communication is being shared assumes a lot of similarities across the board. So messages should be changed with regards to that. We also came up or took away the fact that it's very important to understand how the epidemic is evolving. And so our messages need to evolve with the life cycle of the epidemic, if you will. In the second session, we looked at slightly different things. And so now, in this third session, what we want to focus on is this whole idea of, in very general terms, okay? This whole idea of our approach, has it been appropriate? Has it been over-medicalized? Are there any pieces that we are missing? If there are any, what are those pieces that we are missing? And how can we be able to address them or structure ourselves better in order to be able to realize the desired goals? Now, to help me unpack this topic, I have with me an excellent panel, if my opinion, would be asked. I am joined by Dr. Jackie Kitulu, the president of KMA, and also the first deputy governor of the Kenya Red Cross. And wearing both those hats, she's been very instrumental, at least at the national level, in terms of advising or steering how conversations are going from that perspective. I am also joined by Dr. Chitai Murabula, a consultant psychiatrist with the Ministry of Health, who likes describing himself as a mental health literacy and advocacy enthusiast. Okay. In essence, I think it would be very interesting for all of us to hear from him with regards to how to address some of these psychosocial issues that are coming up. He's also an official of the Kenya Psychiatric Association. My third panelist for today's conversation is Dr. Janet Murioki, an old friend who's also a public health specialist and a medical doctor by training. She's the country director of IntraHealth Kenya. And interestingly, for our conversation this evening, she's also the project lead for the USAID-funded Human Resources for Health Kenya mechanism. And then finally, I have Dr. Maxwell Okoth, who is a physician and who's founder CEO of Ruai Family Hospital, correct? Good. So with this panel, or 4, we are going to unpack this thing, today's topic that we have titled health care and medical care. What are we doing and what should we be doing? Now, the choice of words is not inadvertent, okay? And just to make sure that we are on the same page, when we talk about medical care, normally it's an old terminology, but the precise use of the term is usually reserved for those engaged in the diagnosis and treatment of illness. So it has to do more with service being given or medical attention being given to somebody who actually needs it from that perspective. It's usually provided by a bona fide health professional. So think physician, think doctor, think nurse, you know, in this sense. On the other hand, healthcare is a much broader, takes on a much broader perspective. So it covers the full spectrum of health, and its focus is on the monitoring or the maintenance or the restoration of health to the public in its entirety. And so in this sense, therefore, it can be provided to at individual level, at family level, at community level, and so on and so forth. So if you will, medical care is actually a subset of the wider discussion around health. Now, by having a panel, it means I was not the one who was supposed to talk all the time. My panelists need to speak, okay? And so the first question that I would want to sort of like put out there to my panelists to get the ball rolling is that I think all of us are quite clear that there have been very many directives and initiatives from the government, okay? You know, ranging from limitations in movement, okay? Ranging from what we need to do in terms of masks and hand washing and social distancing and all these sorts of things. Of course, not being done solely by government, but being supported to some degree by the not-for-profit sector. But my experiences may be different from yours. What do you think that these directives are having the desired effect? Okay. What has your experience been? Maybe let me start with Jackie, okay? Are Kenyans behaving? Are they keeping to social distancing? Are they staying at home during curfew? Are they wearing masks appropriately?
Thank you very much, Dr. Ben Goy. It's a pleasure to be here and with such a wonderful panel. I like that question. Are Kenyans behaving? You and I are the Kenyans. Are you wearing your mask? Are you social distancing?
I wear mine in the Kenyan way. I wear it around my chin here.
And maybe on your forehead as well.
There you go.
and I like the way you've asked the question from my experience. In the last 6, 7, 8 weeks, I have actually sat at the National Coordination Center for Quarantine and Isolation Facilities, one of the measures that were put in place in terms of dealing with the pandemic. And so I'm moving away from your masks and that bit, but looking at some of the measures that have been put in place. And I bring it up because it's been a hot issue about the quarantine, and is it necessary? Should we have done that? Should we not have done it? Is it the best way? And I must say that having been there those 8 weeks and looking at where we've gone through, we started from a point where actually all our cases were technically imported. So that measure to say that they would have mandatory quarantine, I think at that point in time made a big difference. So the first 200 cases that, of the first 200, I think about 140 were all from imported cases and from cases that were in quarantine. So if you, in terms of looking at those 140, if there had been no mandatory quarantine and they had gone home, look at the dispersion. How many more cases and how many people would have been infected? So if you ask me about that measure, I think that measure did meet its mark. Now, in terms of the process of it, of course, that was again another learning curve. We hadn't done anything like that before. And I think if we are looking now from week 1 to week 7, 8, where we are now, that process has gradually changed with different structures in place. So when you're asking about measures, and I've only talked about one, but those are measures that I think you learn with each week and with experience. You have to transition how you implement those measures. So even the measures of mandatory quarantine, and then assess who's at risk and say, okay, so maybe the ones who are at high risk, we should look at a solution to how do you self-quarantine and set up structures to ensure that you have the right people do that. So the measures that we are taking, I think they do have their impact, but they continually need to be revised and targeted in a different way, so that there's that fatigue that comes in with any measure that restricts you in one way or another. So we need to be constantly looking at it, even at the point of saying that if most of our cases are asymptomatic, so if the ones that are positive, so if we isolate all of them in hospitals, then what does that do to the capacity? So maybe we need to rethink that and say, okay, if they're asymptomatic, maybe you isolate them in a different context other than a hospital. So I'm just looking at the measures. Yes, they do make a difference, but they constantly have to be revisited and revised to move with the trends and to ensure that they continue to meet their targets.
Thank you. Thank you very much, Dr. Kitulu. But Dr. Chitai, I think Dr. Kitulu is being a little too clever. She's picking the one thing that she knows works, and we all know that the face of COVID is the mask. Now, you and I both know that we wear these masks in very interesting ways, okay? Right from wearing it on the wrist, on the chin, dangling on one ear like an earring, okay, on the forehead, sort of like trap sweat and many other things. Let's drill this down to the individual. What is going on? Why are people not, at that level? Why are they behaving in this way?
Okay, thank you, Dr. Angoe. And I'll come to the mask bit, but let me start from another place.
Okay, go.
And we can start by classifying Kenyans in terms of their obedience to these rules or adhering to these measures in 3 categories.
Mm-hmm.
One, are the Kenyans who are adhering to them because they are afraid of the government. Because the government says it, and it's government. I don't really understand the importance of this, but since government knows better, then let me follow them. Group 1.
Okay. So the German rule, you follow the rules because you fear punishment.
Because the government is colonial and they have the power over people. So they just follow the rules. So that's group 1. Group 2 are Kenyans who have read the information. They do understand the measures, and even beyond the measures by the Kenyan government, they have also maybe read other sources like the World Health Organization instructions and truly understand the benefit of these different measures. And so they follow them because they understand out of volition. So that is the second group. And the third group are Kenyans who feel that this pandemic is really, the coronavirus is not my problem. First, perhaps because I'm not at risk. I feel that I'm not at risk. I feel just a flu like any other. And it affects more maybe a social class that I don't belong to. And this pandemic was brought by those who are rich and who can travel out of the country. And therefore, and I have more immediate problems to think about, to worry about. I have problems, other diseases, where I will get food. So in my hierarchy of needs, the coronavirus is not at the top. So we have those 3 classes. Generally, there could be others, but obviously you can see that group 1 and group 3 pose a problem. Group 1, those who follow without questioning, because the government has said they may protect themselves for a while, but also they will suffer from fatigue. Group 2 is good. They have understood the measures, why they are wearing the mask, why it's important social distance, and so on. They are less likely to develop fatigue quickly. Group 3, those who seem that they are also problematic because they expose themselves to a risk, but then I don't really blame them. I don't blame them. The group 3, the ones that say that now this is not my problem, and I will not obey I'll not follow these orders, because If you look at the pandemic virus, the COVID, since the beginning, there have been a lot of low moments that could have led at least a good number of Kenyans to fall into the group of those who say they don't care. One of them is this: the landing of the Southern Chinese Airlines with 239 passengers from China at a time when already in China, it was already, the virus was already causing havoc in China. You know, it was a high risk zone, but we let it land. So we lost trust at that point. There have been other low moments, and you can talk about even the way the measures were brought in when we said, okay, let us now contain the virus. The restrictions that were brought in, there was an overuse of security forces to clamp down on people, who are disobeying the curfew, and the curfew itself meant that if you disobey, you are taken to quarantine and you're punished for it. So there are those problems. There are issues of accountability on the part of the administrators, and this also further erodes the trust that Kenyans have. And you can go on and as people continue to understand how this virus spreads, then they are starting to question some of the measures, like Dr. Kitulu was saying, that there's need to continuously revise these measures, otherwise you lose trust from the people. And when you lose trust from the people, no matter how much force you use, human beings will behave depending on what is good for them. So we should be revising the measures. Even at this point, look at something like a curfew. So, in the scientific sense, how do you justify restricting movements at some point in the day and having people all crowd within the day instead of opening up and spacing out so that people can do some of the activities in the night, some of the economic activities at night, and so on. And also, you know, this crowding even at bus stops, this is the reality of Kenyans. They have to rush to beat the curfew because this is a government directive. So if you look at some of these factors, look at the restriction in and out of Nairobi. If you look at it,
So in brief,
people are restricted. Let me finish this point, okay. and I'll let you now talk. People being restricted from moving in and out of Nairobi. To me, as a medical doctor, I would understand the restriction of people moving out of Nairobi, but how do you explain restriction of people moving into Nairobi in the context of the epidemiology of the coronavirus?
Okay, so you bring in a couple of provocative issues there, Dr. Chitai, but I may want to sort of like summarize in this way that if I get you correctly, you are talking about initiatives being divided broadly into two. There are those that seem to be quite non-empowering, such as curbing the freedom of movement, you know, or top-down directives that seem to come through without a good understanding of the social or base of the pyramid realities. And then there are interventions that, you know, on the one hand, which was an implicit thing in your argument, that could be considered as empowering interventions. And probably maybe we haven't gotten to that phase yet, where we have interventions that empower people to be able to make healthy choices or to have direct control over some of these things that would interfere with their health. Then the other bit that I seem to get from you is that this whole idea that it is actually the health is a collective process. There's a role for the individual, there's a role for families, there's a role for communities, in as much as there's a role for government. And that then takes me, of course, you know, the complexity of health requires that we focus, or we have a much more broader focus on health, which brings in means that we have to sort out some of the social determinants of health. And you have raised them, looking at the issues of housing and overcrowding, looking at the issues of transport, looking at the issue of economics, which makes people move away from there. And naturally, that means that we have to go towards a greater integration of public health and clinical medicine. Dr. Okoth and maybe Dr. Muriuki, how do you think this can be achieved, this integration between public health and clinical medicine? Because it seems like they seem to be moving sort of like parallel paths, you know, with no idea as to when they are going to come together or confluence.
Okay.
I start with you, Doctor. Yes, who do I start with? Dr. Murioki?
Yes, first. I can take it. Yeah, thank you very much, Ben, and my fellow panelists. I think the discussions have started off on a very good note. So addressing the question, I think, at hand on how do we bring public health and medical care. I think as we look at COVID-19, it's already teaching us a few facts. We really have to start looking at the basics. And the basics come out of what is the action that people must undertake to prevent this disease. One, it's just listening, then doing what you're being told. You're being told to do your hand washing. You're being told to wear your mask as we've been directed. We are being told to social distance, stay at home. We are being told if it's to the financing, use mobile money, don't use cash itself. So all these things are changing our behavior. And this is for the preventive part of it. And I think when you look at prevention, it also talks about to health education, which is a promotion part of the healthcare. And it's really integral that we concretize that kind of support, especially at our community level, which is our level 1, because this is where we are going to change our behaviors and the willingness of people to comply with all these government directives. I think here in Kenya, we have actually been quite fortunate. When you look at the West and the East, COVID-19 has been brutal. And this was some of the richest countries in the world where we saw a lot of hospitalization, and it began from the onset. So we saw a strain on infrastructure. Our nurses, our doctors, the entire health personnel was overwhelmed. We saw a great utilization of the hospitals. It also put a strain when deaths were so high and the mortuaries could not take on the brutal effect of the disease. But when you look at Africa, I think God is gracious to us. We are seeing asymptomatic cases at about 76% compared with 24% of the symptomatic. So for us, I think when you look at our statistics, it is telling us that we need to focus on our preventive care and not neglect the hospital, but prevention is what currently, based on the directives, has enabled us to flatten the curve in a sort of way. When we were at day 30, we had just under 200 cases, but at day 60, we have seen close to about 750 cases. When you compare with other countries like South Africa, the increment has been almost close to 3 or 4 folds. We in Kenya are looking at about maybe 2.5. So for us, that is really a great help. So we need to continue refocusing on prevention and promotion while preparing our health facilities.
So the evidence is there, Janet. Allow me to interject a little bit. So the evidence is there that health promotion works. I mean, if you are a student of public health, you will realize that more lives were saved by simple things like hand washing and antiseptics, clean water, better housing, etc., than any pill or any drug or any vaccine that we've ever put out there. So the question then is, over time, we seem to have been following these two parallel paths. Okay, every governor who came in under the new dispensation was just about, I need to have a level 5, level 6 facility in my county. You know, even when the responses first came in this country with regards to COVID, it was just about ventilators and ICU facilities and this kind of thing, which is medicalized care. But what you're telling me is that the basics is what works. So what do we need to do to bring these two together? That is the core of my question. Can we be able to bring these two together?
It is possible. And I think this is where you bring public health experts and the medical experts to sit around that table to discuss how we can move away from the medicalization. Where do we put the investments? I agree with you. Everybody was mirroring what was happening in the West, what was happening in the East, China especially. But I think what is happening in Kenya is showing us that we don't always have to go that route. We need to put a lot of emphasis and resources on risk communication. We need to do the contact tracing. And once we identify the people, then hand them over to the medical care. And this way, the issue of, I think it's putting the right investments in the right place. And this is what will allow us to have a more global and what we call a public health approach towards dealing with the virus at the moment, rather than putting too much emphasis on the healthcare infrastructure at the hospital level. But we must not neglect it. We do not know what could transpire in another 30 days, which will be our 90-day mark. So we must continue the preparedness. We must ensure that all these nice inventions we are seeing by our university students, let's prepare for ventilators. Let's prepare our health workforce to deal with it. But we must focus still on our community. So that our health experts, our medical experts must sit around the table jointly and do interventions. And we have seen that the ministry has put in place technical working groups on the human resources COVID technical working group at the ministry. And we're really looking at how can we prepare this workforce? What are the numbers that we need, both at the community and also at the facility level? What are our projections? And we were trying to do scenarios of the kind of mix. And this mix is actually demonstrating that there are cadres we have not been taking care of. When you look at the level 1, we need skilled professionals, not unskilled. So who are these skilled professionals at the level 1? We may talk about the community health extension workers. Our dispensaries were always manned by certified enrolled community nurses. We have our public health officers. This is the workforce we need at that particular level to bring about that public public health approach. Then we go to the next year, we're looking at the health centers and the hospitals. This is where we now need another kind of skilled workforce. Our clinical officers, our doctors come here, and up to the referral hospitals. We are looking at even occupational therapists or chest physicians actually playing a critical role in management of our very severely ill patients. So I think as we continue looking at the workforce that is required, there are two aspects. But at the discussion table, the people who are concerned about those two levels.
Sorry, Janet. Please leave a few answers for Maxwell to also shine. But carry on. Briefly.
Thank you. I will.
Yes.
I will give him the space. I think the other thing that is coming out in terms of healthcare and the medicalization is how we also are going to define quality and care. This is something that has been misunderstood as we have medicalized our profession. We have all these guidelines. We have, and even now with COVID, we're looking at continuity of services. But at the lower level, we have not had good supervision of the preventive and promotive services. How do we ensure quality? Services are being provided, and also the care that is required at the home front is actually going to be provided. So I'll hand it over to Maxwell to continue, Adi. Thank you.
Okay. Maxwell, make it brief.
Yes.
Your comments with regards to this particular question. How do we manage these two? And I particularly feel for you because, in my view, if this integration is not brought on board, the likelihood of facilities such as yours being overwhelmed by the worried well, okay, is going to be very high. Okay, so carry on.
I think we have done very good things as a country, but there are also areas where we have not done very well. We are more of a reactionary nation than being a preventive nation. If we all remember in the 90s, a public health officer was a very senior person and was a very respected person. Along the way, I think this changed. And if you're going to tell people to wear masks, social distance, sanitize, hand wash, stay at home, and then we do not go to the ground to actually ensure that some of these things are being implemented, then we are getting it wrong. The issue of locking some counties is a very good move in the first place, because you actually contain the spread to certain regions. But my worry is, for example, if you look at Nairobi today, I think we are lying to ourselves to think that we are managing the spread of this infection. Because I don't think there's anywhere that is written corona spreads more at night than during the day. Because you go to the city center during the day today, it's chaotic. So you ask yourself, are we making progress, or are we actually prolonging the spike of this infection? Because my fear and worry is, yes, the healthcare system, we would want to look at the medical side, but we need to look at it holistic in a 360 approach, from the preventive to the supportive. When we start looking at the preventive, you'll realize people will stop forgetting the medical side. Then things come to the medical side, then we come back and react on the medical side and forget the preventive side. We need to actually look at all these things as an ecosystem that they coexist together. That we need to prevent, and in case we don't manage to prevent, how do we handle the spike? Because now we are going to start saying, let us manage the preventive side, and everybody will forget the medical side. Then all of a sudden we find a spike and our hospitals are overwhelmed, and we had not planned for that. You cannot separate the two. They have to go hand in hand, they have to go together. So we need to empower the public health unit as a unit in this nation. And that is one thing I think we have failed considerably, and we need to accept that. Let us empower the public health sector. Right now, I know restaurants are being opened, and I will ask you the questions. How many of you have gone to some of the restaurants in town today? Are most of them sticking to the guidelines that they've been given? So we need to actually say, yes, we have very good intentions to manage this thing, but the way we're implementing it is wrong. Instead of having askaris bundling people in lorries to take them to quarantine centers, a public health officer needs to be there to guide on how this process should be done. So for me, to say that we are going to look at them as two separate things is not true. So the body operates as a unit. So they all operate as, sorry?
So just like the idea of community policing, where policing in itself is not for punitive purposes, but rather to bring the community on board. The idea should be like what was happening in the coast. If I don't have a mask, give me a mask, or tell me the importance of a mask. If you come to my establishment, it's not about bundling me into a lorry, but use that as a learning opportunity for you to be able to get in there.
Yes, okay. Because you need to realize every person is a weak link in the fight against COVID. Mm-hmm. I might actually protect my family, ensure everything is done, change my clothes when I step on that door, enter the shower, just the nearest shower in the house. But there's that one weak link. If I don't sit down with my house help and try to bring her on board and make her understand why I'm doing some of these things, then I'm actually, everything else that I've done is wasted. Okay. So everybody needs to be brought on board to actually realize what are the benefits of some of these things we are doing. Mm-hmm. Number one, so that is on the preventive side. On the medical side, also be prepared. But you see what happened? When this thing came, we were buying ventilators. How many ventilators have we needed during COVID? Those are resources we'd have actually used to ensure that everybody has a social distance space, everybody stays at home, are they fed so that they don't have to feel like they're going to town every day. And we need to look at this thing. And there's no way you can segregate some of these issues. You have to look at them holistically, from the economic side to the social side, and then the health side of it. They do not work in silos.
Thank you, Dr. Okoth. So in brief, this needs to be a very deliberate effort to actually do two things. One, strengthen a public health or community health approach, while at the same time not neglecting the medical aspect of health, number one. And number two, having strengthened those, work very deliberately towards bringing these two together so that they are not in competition, but actually working hand in hand to be able to deliver on this ideal of healthcare. But then it brings in an interesting point. The the issue of sustainability. And I will go now to some of the questions that the participants are asking, because I have a question here from Juan Boniface Mburugu, who says, I'll read two of the questions that relate here. You know, are we likely to come out of the curfews and partial lockdown, or are we headed for total lockdown? His other question is, we have washed these hands thoroughly, we have sanitized, we have stayed at home when we can, we have worn the masks, but for how long can we keep doing this? Okay, so essentially his questions are bordering on the sustainability of the interventions that we have put in place. Okay, now I want to put this to Dr. Kitulu. And the idea that I want to put for Dr. Kitulu is this. So far, most of what we have been doing with regards to COVID-19 have been from a very dedicated, from a very standalone campaign type of perspective, with dedicated funds, technical working groups, you know, specialized staff, etc., etc. And to echo what our participant, Burugu Boniface, Dr. Burugu is saying, this is expensive and is not sustainable. And the idea is that for us to bring in sustainability, we need to work towards integration into the general health services. In fact, I also have Eric Petty commenting and saying that why is it taking time to integrate COVID-19 into the TB program? So, Dr. Kitulu, for us to be able to sustain this, we need to find ways of integrating COVID programs into general health programs. Can we do this? What challenges do you foresee with this?
Thank you,
Ben. Is this really the direction to go? Over to you.
Absolutely. And I think what we are talking about here is the concept of building back better. So that the disaster response, right now we are looking at everything, and as you've put it very well, all the issues are around COVID response. But this disaster response actually should strengthen the existing systems to make them resilient enough to handle regular needs and periodic shocks. As opposed to right now what we're doing in terms of creating new temporary solutions, which are addressing the pandemic specifically, and then once the pandemic is over, that will dismantle them. What we should be looking at right now is that out of this pandemic, our health systems should actually be strengthened. We should take advantage of this pandemic actually to reshape those deficiencies that we are talking about. The discussion indeed has been, you put it, you started, is it preventive versus curative versus promotive? Is it public versus public health care versus, you know, medical care? And I think they are all part of a system. And this pandemic just shows our deficiencies in that putting together of that whole health system. So what we are doing right now then, in terms of whatever responses, they should then be targeted to making the system better. Let's build it back to make it a better system. So that when we are talking about the challenges of human resource, and I like Dr. Miruki has elucidated them very clearly at various levels, that there's been a deficiency. And you're talking about, Dr. Miruki, you've talked about a shortage of, public health officials even at level 1. If you go to the curative side at level 5, 6, you talk about shortages of curative experts. It's a spectrum. This is the time to say, okay, these are the deficiencies we have. How do we build into them to ensure that if we have a pandemic, the system will respond at whichever level, from level 1 all the way to the top, from the community all the way to the specialized service, rather than jumping, as you've said very well, jumping into ventilators. And you'll say you'll buy the ventilators, then you'll realize, oops, we've got the ventilators, but we don't have the personnel to run the same. We don't have the ICU doctors, we don't have the ICU nurses, so then we have a deficiency there. So this is the time for us to make our system more sustainable from a point of integrating all the things that are needed to respond to whatever it is. The pandemic shouldn't be the shock to make us create a parallel system and say, we'll have an isolation center only, this will be a COVID hospital only. The COVID hospital probably, it should be, on a broader base, infectious disease, or maybe a facility which, even if in that county, is the one that can respond at the highest level. But even the high facility in a county, without the basics, without the community level interventions, it serves no purpose, because how do you get the right people coming to the center if they are not referred through a system that starts right at the basis? So this pandemic, and some people say do not waste a good crisis. This crisis should be getting us to build back better. All those deficiencies we've looked at, let's not look at it as fitting it only for COVID, but building the system to ensure that it will deal with all the regular things. And right now that's a challenge that we are having. I was speaking with a pediatrician based in Machakos, and they said that, they are losing children because of lack of, in one of the facilities, they didn't even have an SpO2 monitor. And they're saying, this child, even starting from the home level, in terms of it's a newborn child, was there anybody who could have spoken to them to tell them, that you have a newborn child, maybe you don't go to the nearest chemist and buy medication to give a newborn child. Even just that information like that. So that by the time they are approaching you and they, it's a really severely ill child who then subsequently succumbs, it's because systems were not in place to ensure that they got to the place in the right time. So this is the time for us to step back, and as Dr. Muriuki said, yes, all of us come together and make sure our system is responsive from a preventive, promotive, from a curative, rehabilitative, all those parts are integral to the system, not just to respond to COVID.
Okay, and I hope that I want to task you with this specifically, Madam President, because in the spaces that you sit, we need to move from rhetoric to action. Okay, the thing is, we know this, but is there, to build on what Dr. Okoth was saying, we need to have a plan or a structure that can actually take us to this new reality. James Amenge, a participant, is commenting here, that the benefits that we can be able to derive from this are huge, including addressing other respiratory infections such as TB. But the thing here is this: so long as we continue to have this solitary focus on COVID to the exclusion of other ailments, then it's highly likely that we are going to lose the ball. Dr. Murio?
Actually,
yes, sorry.
When you say that, when we focus and all our attention, as you say, the task force, the monies, there's funds being raised specifically for COVID response, we are forgetting that we have all the other things remaining as is. We have the TBs, we have the HIVs, we have the diarrheal diseases. Well, maybe the diarrheal diseases have come down because we are washing hands more. But all those other things, the cancers, they are all still there. So the system cannot just suddenly shift to respond to COVID and forget about this. And yet
we are losing
all
you,
COVID
Jackie.
can be dealt with within it. Yeah. Yes?
Oh.
You lost me? Hello?
Okay. My apologies. We seem to be... okay, there you're back. Sorry,
So
we missed out on a bit of what you said, Dr. Kitulu.
Yeah, sorry. And I was saying, in terms of all the other illnesses that we have out there in the community, mental health illness, cancers, everything else is going on. And right now, actually, our challenge will be deaths more from these conditions rather than from COVID, because then people are scared to go to facilities to get treated. People, even some of the directives that had been given initially to cut down on elective, procedures and things like that, all those actually keep people away from dealing with issues. So when we have a silo approach to this treatment, to the management of COVID, then we risk a lot more, in terms of the existing illnesses and existing challenges that have been in society, because then they get sidelined for the COVID.
It's important that it's interesting that you bring that up, because I can share a little bit of personal experience here. My own father has had 2 acute episodes. He's a non-hypertensive simply because he cannot access care. And the understanding out there when he goes to these facilities is that, you know, we are organizing ourselves for COVID. You can't come here. You'll get infected. You are old. You're all these sorts of things. So unfortunately, this is the situation that has been the case. I have also, in another sad turn of events, lost 2 friends and 2 colleagues to cancer in the last 2 weeks, basically because of what we are talking about, because the institutions, or some of them as far as they're concerned, you know, right now it is COVID start, middle, and end, all right? Now, but you bring in, you mentioned something here that sort of drives me now towards the mental health angle. And I can see it's the same concern that, who was it who was asking here? I think I've just scrolled through it. Somebody also was asking about mental health. The issue of mental health is one of the issues that are coming up, Dr. Chitai. And how can we be able to, is this an opportunity for us to be able to sort of like put it out there, the problem of mental health in our societies? There are issues of stigma also that we haven't really addressed that are likely to come up with regards to this. Are you seeing an opportunity here, and how do you think we can be better able to integrate this into the general outlook of things? Dr. Chitai.
Yeah, thank you very much. And let me just say that I totally agree with what Dr. Kitulu said before about the need to understand that other illnesses are still going on, and they were there before. And to an extent, we were overwhelmed by them even before. Even before COVID, for example, the treatment gap for mental health disorders was about over 80%, meaning over 80% of mentally ill persons in Kenya don't get any form of health care. So we have to understand, and we have to go back to the basics and ask, why are diseases diseases? Why do we call some conditions diseases? It's because they cause pain, suffering, and death. That's why they're called diseases. And when death occurs, it is equal. Death is equal. Whether you will die from suicide, or whether you will die from pneumonia, or whether you will die from TB or cancer, all deaths are equal. If it occurs to you, you've lost life. And therefore, we must have that in mind. With regard to specifically mental health, there are different things. There are some things we can look at here. One is that different segments of the population at this time will experience mental health differently, different challenges. First, of course, are those who already had mental problems living with them. They'll have difficulties because they may relapse. One is because they may not access medication, just like the hypertensive patient or diabetic patient, because healthcare maybe has been stepped down. The focus is on COVID. We have those who may get mental illness for the first time because this is a stressful moment and because of the losses they are incurring, either economic-wise, or because they are losing loved ones, or because they are becoming sick, or because you are losing freedom because now you are locked in the house, or because of the things that are happening in that house, including domestic violence or gender-based violence. So that's a very important segment of the population. We have, of course, the health workers.
Not forgetting alcoholism, Dr.
Yes, not forgetting alcoholism and all forms of substance abuse that can be taken up as a form of coping mechanism because you are feeling uncomfortable and you want to do something. Actually, anxiety is bad, really. Feeling anxious and not knowing what will happen tomorrow or 2 weeks from now is extremely harmful to any person's mental health. And so we are looking at these groups, and you look at the health workers. If they are exposed to working conditions that expose them to infection, they'll worry about getting sick and also and being unable to work, and everyone fears. If you are in hospital, you know, and you are not protected, you fear. So these are the challenges. And then you have those who are either in quarantine or they get infected. So quarantine, poor conditions in quarantine can also trigger mental health problems. You are there, your quarantine is over, it's extended for another 14 days, and you don't know why. You know,
if you continue with this list, I'm also going to get a problem.
Let me stop there, but
it's
also
a very long list, yes.
but also touch on the stigma and say that
yes,
also
please.
Stigma against persons who have recovered is a problem that may need to be tackled. But let me just say this. where is the opportunity in strengthening the system so that the mental health of Kenyans is better post-COVID? One, I'll just make one suggestion. I can make many, but I'll make one. And one that will be very effective is actually to train health workers in mental health care as we train them on COVID. So it can be touched because COVID also has mental health implications. So just as we train health workers across the country, in the counties, about the response to COVID, let us also allocate resources so that they are trained in mental health. I can just even stop there. And if we do that, we will have strengthened the system for posterity.
Okay. Thank you.
Ben,
Thank you very much. And
Ben, may I pipe in there?
Yes, go ahead, Dr. Kitulu.
On the mental health, as Dr. Chitai has said, for you to realize the need for mental health amongst healthcare workers, we as KMA, we've had mental health webinars every Tuesday. So there's one actually going on right now from 6:30 p.m. Our second webinar had 3,000 logins because we've maxed out our Zoom at 500 and the rest engaged through Facebook. 3,000 people, just showing the need for mental health support for healthcare workers. So that indeed, that's an uncharted territory where when you're just talking about the caregivers themselves looking for that care. So imagine those who need the care. So it is a big area.
Yeah. No, that is very true. And I think you've sort of like, if I can summarize, and I hope now you've addressed some of the concerns. There were questions and comments there from the likes of Harendra Patel, from Wangare, and from a couple of others asking on this very thing. The panoply of mental health issues that come up is quite huge, but we can take advantage of the resources available through these emergency funds for COVID to actually layer on additional modules for training, taking advantage of that then to equip our health providers far much better than we are now.
Can I just comment?
Yes.
That the Kenya Psychiatric Association is actually having a whole month campaign on mental health awareness for the Kenyan public in the month of May, and it is going on social media. So if you check the Kenya Psychiatric Association page, you will find lots of advice, videos, written text on Twitter. If you check hashtag mental health 254, you'll find a lot of educative discussions going on. Okay.
Well, what was that again? Mental health 254?
Yeah, you said? Hashtag mental health 254 is the hashtag that we're using to educate Kenyans on mental health.
Okay, excellent. Thank you very much. Now, there is a specific question here that maybe I might want to have you, Dr. Okoth, speak to. I know I cut you off at some point in the middle there. Forgive me for that. And somebody is asking, it was a question about access, how do we ensure access to quality, affordable, and accountable health care, not medical care, but health care? What are some of the ideas that you can be able to share with us?
First and foremost, to tell you the reality on the ground, if we do not come in to sort some of the costs that are involved in bringing the cost of healthcare in general high, then we are looking at a future where the cost of healthcare is going to go up. Why am I saying this? The supply chain in healthcare today has not even tripled or multipled. They have gone in tens. If you look at the cost of doing some of these basic procedures, a basic face mask that was going for 4 shillings is now going for 100 and 150 shillings. These are the costs that eventually are transferred to the patient. And as a government, because that is a person who has a controlling arm, we need to have a way to be able to cushion healthcare, because healthcare is a social thing. It's for everyone, whether it's private or public. There are costs that you cannot run away from. Human resources, number 1. Pharmaceuticals, number 2. Those are the biggest overheads in healthcare. So if you want to bring the cost of affordable healthcare, and everybody wants to bring affordable healthcare, nobody wants to make healthcare expensive. And we need to be very clear on this. But who are the players that actually push the cost of healthcare higher? You get me? If we can be able to control the supply chain for pharmaceuticals, there's a cartel that would be able to ring fence some of these costs sometimes. I think the government needs to whip itself and bring some of these things down. And we've heard severally that cost of healthcare is cheap in India. Whether that is true or false, I do not know. But one thing we know is the cost of medicine and drugs in India is cheaper than it is in Kenya. What brings the cost in India cheaper more than it's in Kenya? Is it the taxation model, or is it the costs and overheads that people are putting on these drugs? That is a very key area that would be able to bring the cost of healthcare down. They always say that human resource, and there's a time that there's a public outcry that the doctors are the ones who are pushing the cost of healthcare. That's a falsehood. Because I will tell you, a bill that comes to you is not just purely a doctor's bill. It is a mixture of very many things. And like I always say, you look at an issue holistically as opposed to looking at it from a one single-eyed perspective. First, deal with the human resource. If there are very many doctors available, a certain cadre will not feel that we are special and we want to charge as much as 700,000 for a procedure. So if you can be able to train as many healthcare workers as possible, the cost will always just rationalize itself. If you can be able to control the supply chain for pharmaceuticals, the cost of healthcare will come down. But unless we sort some of these things, then we are going to be burying our heads in the sand and say we want to bring the cost of healthcare down, which is a lie. For example, I will tell you, NHIF had said that let us capitate Kenyans, and I'm sure Madam President is in that board, for outpatient. And then they pay a facility 100 shillings per month to offer this service. What will happen is this. For every person who walks into a facility, whether it's government or private, the least you can spend for an outpatient visit is 2,500 shillings. So the question is, who pays for this 2,500 shillings? In the government sector, you'll say the human resources role is coming from the government. In the private sector, the private hospitals have to meet these costs to be able to meet their costs. So how do you go and pay somebody 100 shillings when somebody will come and take that 100 shillings for 20 people? The assumption is it's a capitation model, but in our system, it's not actually a capitation model. It's an adverse selection. People who actually go to choose a facility are people who need the service. Most people will actually not go and choose that service. So if we want to address the real cost of healthcare and look at it with an objective mind and honesty to bring this cost down, we need to sort fundamental areas. And first and foremost, more than anything else, is pharmaceutical supply. There's no way you can explain to me why meds will sell a drug for 30 shillings and the same drug is being sold by another supplier at 1,000 shillings. But the producer is the same. So there's a problem somewhere.
So in brief,
as long as this person is buying it at 1,000
what you're saying,
yes, the cost will have to be transferred to the patient. We need to sort from the pharmacy side, number one, because they're very substantial contributor. Yes? You're saying something?
Okay. So if I hear you correctly, although you have singled out that and you've talked about payment mechanisms, yes, if I hear you correctly, what you're basically saying is that we need to look at the entire value chain.
The entire value chain for health service, yes.
Of what goes into the production of health.
Yes.
Okay. And so this means looking into the inputs and the costs of those inputs, whether the inputs are the human resource or the expertise that is required in there, whether the inputs we are talking about is in terms of the medical supplies and equipment and so on and so forth. We need to look at the processes or how the health system is structured to be able to produce these healthcare that we are talking about. And then we need to look at some of the cross-cutting issues, the human resource, making use of technology, IT, and so on and so forth to generate efficiencies that can then be able to be passed on. And that this is
hello?
Yes.
There's somebody who's saying that he differs with me. Just to answer, Sarah Agak, the issue of pharmaceutical is not isolated to the COVID era. I'm talking about an issue which has been
I can see the question, yes.
Yes, so the COVID era, of course, we understand there was a disruption in supply chain and raw materials and all that. But then again, there's also a dishonesty in that part of it. It does not justify the levels of price increments that we saw. We cannot justify some of those, yes.
Fair enough. So what I'm trying to say here is that, I mean, you know, so this is one element. So we have to look at it, and we can sort of like go into the details of each of them. But the basic idea is this, that it is possible for us to look at that value chain and look for opportunities that we can be able to tweak, adjust, and move accordingly, generate efficiencies that we can then be able to pass on to the end consumer. And in this way, we will be able to get this. Dr. Morioki, I want to very quickly get your input in on this. This was a question from Jamal Gohil. How can we improve our healthcare system going forward in terms of affordability and access? So essentially, it's still the same question. We are talking about quality, affordable, and accountable healthcare. Okay, so Dr. Okoth has talked to us about the, you know, looking at the value chain. What else? Is there anything else we can do?
Yes, thank you very much, Ben, for that question. I think on my perspective, just building on what Dr. Okoth has brought out, we need to take the services closer to the people. I think the cost of healthcare is actually increasing as we move up from our dispensary to our referral hospitals. And in the spirit that we have currently been having in the country of universal health coverage, the services need to be at that dispensary level, even from the community level. That is where the services needed to be provided. And because when you look at a cost of a consultation at the dispensary vis-a-vis a hospital, whether public or private, the cost will go up because you're dealing here with higher caliber of healthcare. Your healthcare workers, you're dealing with higher caliber of infrastructure, including the equipment. So having the services at the lower level makes them affordable and ensures that issue of equity is taken care of. The other thing that will actually play out here is also how we engage the private sector. I think just as we talked about medicalization and public health, bringing in the private sector and building a system of public-private partnership, even in the management and governance of healthcare, is actually going to be very critical in making services affordable. Of course, we may have to tame in our private sector with prices. I think that is what Dr. Okoth has brought out. But at the same time, they are also in spaces that the public sector may not. At the same time, they could also complement each other and facilitate lowering of cost of services. The other thing that is happening, of course, we know that those who have health insurances may be abusing them. But in this period of COVID, we are observing fewer hospital visits. And when it's good and it's bad. Fewer in that the people who need the services are also not going, but those who have insurance and have been misusing the insurance are also not going. So it's a double-sided coin right there. The other thing I think we would need to look at, and I had alluded to it earlier, is now also defining quality, because this is also what makes things affordable. And it is people's perception of quality relies on kind of like the infrastructure that they are seeing rather than the competencies and the knowledge that the health worker has and is able to dispense the services. And that is something we need also to build on, ensuring that our health workers have the right skills mix. The other thing is that they have to be available. We have seen absenteeism contributing to our community not going to our public facilities, but rather going now to the private facility. But if we ensure our health workers are really present, they are available, they're in the right numbers, and they're there to provide the services, cost of healthcare will be affordable, both in public, private, and even in the faith-based sector. The other element that we need also to bring in, and it was part of a question that Dr. Kitulu was addressing, is the integration. If we create everything in parallel, then cost of healthcare will go up. I want to go back to our early days of HIV. We were all in fear, there was stigma, and we had HIV clinics, but they are running separate from the main hospital. And this could happen with COVID, but I think the most critical part now is to integrate those two levels of services. You may have streams in the hospital. You have what you could call a clean stream, and that is dealing with the COVID, but it's the same hospital. If you're found to be positive, you're directed in the right direction. If you have suspected, you're put in the right stream so that you're able to have the services in one spot. That integration is going to be really key to bringing down the cost of healthcare, also reducing the stigma, because accessibility of services is critical. In the past, we saw a lot of stigma that HIV clinics were only those who are positive, but when we started integrating HIV into family planning, HIV into TB, things it became the norm. This is not a burden to us. And I think that is also what's going to help the issue of quality and issues of affordability. And then lastly, if I can say that.
Very briefly, if you can, yes.
Okay. I think the other thing that we really have to look at is how do we sustain our services post-COVID? And here we are looking at, in terms of the continuity. I know the ministry and stakeholders have put in place continuity guidelines. How do we continue propelling this? The resources that are available, how do they cater for the right pockets? How do we also ensure that the health workers are in place and they have the competencies to deal with both the medical side, but also the public side of the COVID pandemic? That will allow us to have that level of continuity and bringing in the private sector to also support and other stakeholders.
Mm-hmm. Thank you very much, Dr. Morioki. So to paraphrase for the listeners, there are three issues I believe that Dr. Morioki has brought out there. One is the idea of integration, and we can very quickly go back to our recent experiences with HIV, how it began as a standalone intervention and how it has ended up being integrated in so many ways with TB care and with general medical care. And we find that this is a much more sustainable way of doing things. The second bit was an emphasis on what Dr. Okoth was talking about that has to do with looking for where to generate these kinds of efficiencies and looking at the value chain and passing on these to the ultimate consumer of healthcare. And then the third bit that came out would be to look across the continuum of care. Because if you think about it, when you start with the health promotion, prevention, then when somebody has to seek acute care to rehabilitation, and end of life care, it becomes more expensive as you move away from the home setting into the facility setting. And so her idea is, can we be able to put in a lot more focus on preventive and primary care services, which are at a much lower cost than facility-based care? Now, thank you so much for that. I am being warned that we are running out of time. And so I would want to ask to go around the remaining panelists and sort of ask, you can see the questions that have been put by a number of the participants there. You can pick any that you want, marry them into your final comments, and I'll give each of you a minute or two to sort of just address. Pick any question if you want to pick any, or just summarize your whole perspective on the topic that we are dealing with today. What are we doing and what should we be doing within the context of COVID-19 health and medical care? So I will start with ladies first and gentlemen just before. So can I take Dr. Okoth, and then I go to Dr. Chitai. I finish off with Dr. Kiptulu. Over to you, Dr. Okoth.
Thank you very much. Quite an informative discussion. I think what is coming out from the questions that are here is that there are a lot of issues that Kenyans would want to see addressed, and I'd take is universal healthcare achievable? I'm one proponent who believes that healthcare can be affordable. We have grown as an institution by having a cesarean section being done at $300 over the 7 years that we've been there, and still grown as an institution. What we need to work on is empower either NHIF, because that's the only thing we have right now as an equivalent of NHS, and have this institution have a uniform way of compensation across board. The issue of segregating facilities, that there's a facility that is being paid $200,000 for a surgery, and the same surgery pays another facility $30,000, it's not reasonable. Where you buy drugs are the same, where you buy the beds are the same, where you pay your staff from, because they're trained from the same institutions. Let facilities end up competing on quality of care. When we reach a point where we discuss quality of care as a country, then I believe we have reached that point of growth. So that when you give quality of care, then people will prefer you more, and therefore you end up looking at the economies of scale as opposed to single-handedly supporting certain facilities. And that is what has brought this perception that some private hospitals are making a lot of money from NHIF as opposed to others. This is purely because of this segregation and discrimination in terms of compensation. That should not occur. If we can be able to build this organization called NHIF, I believe we would have done so much in changing the healthcare situation in this country. Over and above that, invest so much in human resources. Human resource for health, human resource for health. No matter what we do, if we do not have people to run some of these equipments we buy, we are wasting time. Thank you.
Brilliant. Thank you so much. Dr. Chitai?
Just keep me for a moment so that I come in next, because there's some noise around here.
Okay, fair enough. He wants to go out with a bang. Janet, I'll give you 30 seconds because you shared quite a bit.
Okay, thank you. I think for me, what I would say is that complacency is creeping, and that's because the virus cannot be seen. So we need to really go out there, invest at the community level, and encourage our population, our people, to actually do the best to continue flattening the curve. Secondly, for me, is healthcare workers. You lose a healthcare worker, you lose a system. So we need to ensure we are protecting them, provide them with the necessary personal protective equipment, capacity build them, and then let's take care of their wellness. Mentally, even from the family front. These are people, they may be in the hospital for 2 continuous weeks taking care of COVID cases, but what about their families? So I think we really need to look at the health worker safety and ensure that we protect our health workers. They are our soldiers out there, and we must cheer them on and let them do their work. Thank you.
All right. Thank you so much. Dr. Chitai.
Yes, thank you very much. Now, let me just say that the first thing is that government should know is living on borrowed time. Eventually, people will get tired. And when people get tired, they will either just disobey the measures, or they either disobey the measures or the measures are lifted because they will get tired eventually. So what do you do with borrowed time? Use it well. So use it well to expand the capacity of critical services. That is the one thing I can say. And also use it well by trying to lift those measures that are not necessarily contributing anything, that are cosmetic, like curfew. Lift those and also look at even restrictions of movement and prioritize which one is more important. Just like I said, moving out of Nairobi is more harmful than moving in. So let people move in, but tell them if you move in, we'll not allow you to leave. And then lastly, one person has asked about the mental health aspect of care in terms of compensation. And it's true. Usually you find that government will plan and talk about psychosocial services, but they don't set aside resources, thinking that these psychosocial services should be free, provided by some NGOs or Red Cross or another person. I think that's a very problematic approach. please
be
as
careful.
you plan,
The Red Cross first deputy governor is listening.
Yes, but I'm sure she'll be very happy that what I'm saying. They should expect the government to actually provide resources for psychosocial support and mental health services.
No.
Thank you.
Okay, fair enough. Thank you so much, Dr. Chitai. Okay, Madam President, Dr. Kitulu, please.
Thank you, Ben. And I think the questions that have gone around a lot about universal health coverage is it achievable? And for sure, I would say it is achievable. And it doesn't matter how much finance we have, because I think the discussion is always pegged around, oh, healthcare financing, we don't have enough. But I think at the center of universal health coverage, if you have the healthcare professionals, and that is all the way from the primary level to the end, you know, from the community level all the way to the level 6 excellent, that is what you need. Those are the most critical, fundamental cog in your healthcare system, because you remove them, then you don't have a healthcare system. Now, once you have those, you have buy-in from the healthcare professionals, and you have an existing working health infrastructure. That is a critical next step, because these professionals or this team cannot work without a system that is working. That is where we should be focusing on our infrastructure, making it serve the needs we've already alluded to, the preventive, promotive, the curative, rehabilitative, that there is a clear referral system where all those things can work. Now, finally, if you have those professionals, you have that system working, then you can get buy-in from the public, because the public will not buy into something that does not work. So that is where you have the public buy-in. And once the public buys into a system that they know, when I go to this facility, I will get the treatment I require, I'll get the people who are trained to serve me as I need, then they will fight for that system. That is where we have then the policies that government sets should be rotating around these things. So that even when you ask this question in the context of COVID response, I'll go back to where I started. We should be building back better. That our disaster response must strengthen our existing systems to make them resilient enough to respond to the shock of COVID, but also to respond to all the other regular needs that we have. COVID is here today. It will come, it will pass. The other needs will also remain there. That is what we should be working to, building back better. This crisis, let's not waste it. Let's use it to build our systems to provide what we are talking about, that universal health coverage. Thank you.
Okay. Thank you so much, Daktari. And, you know, I think my take, given my position, I'm lucky to have the last word. COVID has exposed our nakedness. It has exposed our gaps with regards to disease surveillance. It has exposed our gaps with regards to how our health system is structured. But as everybody has likely has mentioned time and again here, it is a crisis that if we look deep enough, we will find the silver lining, okay? And it is a crisis, therefore, that should not be left to waste, but rather be seen as an opportunity, to borrow your words, Dr. Kitulu, to build back better. So how do we build back better? We need to, if I may summarize some of the contributions that we have had here, we build back better, we start our building back better by moving from this emergency response to a more longer term outlook in terms of how we build our system, point number one. Point number two is that we need to focus on the breadth of health, okay? And not just on the medicalized aspects of health or on any one particular disease, but to find out how we can bring in this breadth, including mental health, physical health, and all these different elements that we need to put in place. Point number three, and which was shared very well by Dr. Morioki and others as well, is that the most efficient site of care is not always the facility. In looking at the breadth of health, there are many sites of care. The first site of care is actually the home, okay? How do we empower and engage with our citizens so that they know that they have a responsibility to take care of their own health? In fact, a phrase that I like putting out there is that health is so important that it cannot be left just to the Ministry of Health alone. We need to bring in other players. We need to think about how to bring in the Ministry of Housing and the rules and regulations that they put in place in terms of building codes and so on and so forth for better airflow. We need to bring in the Ministry of Water, as somebody, one of the participants highlighted out there. We are asking people to wash their hands, but what is the quality of water if we do have it in Nairobi? I don't know how it is out there, you know? So how do we bring that? The fourth thing is the role of integration, okay? The marrying together of these two elements of health that seem to have been moving in parallel so far. And that is the public health or population or community health aspects, as well as the clinical aspects. And that these two need to sort of begin speaking the same language. And we need to maybe, in a sense, even change our curriculums in medical schools and nursing schools and public health schools to be able to allow more all-rounded professionals coming out there. And then the final element from the conversations that we've had today is that we need to move from words to action. And ladies and gentlemen, that behooves all of us. It is not the role of any one person. It is for us to demand it of our governments. It is for us to also step up to the plate and do what we need to do. Thank you so much, participants. You have been very, very engaging on the forum. You've put in a lot of good comments, shared your experiences, and also given us questions that actually have stimulated our thinking. I want to thank my panelists. Dr. Okoth, if you can wave out there so that they know who you are. All right, thank you so much for your insights. That is Dr. Okoth from Rai Family Hospital. Dr. Morioki, IntraHealth, thank you so much. Dr. Kitulu, we call her Madam President because she's the president of KMA. And so we have to acknowledge that, but then she also wears another hat within the Red Cross, which we need to flag. And then Dr. Chitai, who, to be very honest, he had introduced himself as a mental health advocacy enthusiast. And I think we've all seen that shine through. So thank you so much, panelists, for conversation, and thank you participants for making it a very engaging environment. I wish you all a good evening, and I wish you a lovely week ahead. Stay safe. We shall overcome if we all play our part. Thank you. Bye-bye.